Thank you, Rodona. Let me just take 1 minute before I start and welcome Jack Weisgarber, who could not make it to the opening of the conference for reasons beyond his control. I want to repeat what I said at the beginning. Thank you, OAR, for the support and encouragement. That's very much appreciated. Let me move on now to my presentation. I'm going to share with you data regarding morbidity, mortality, and impact of HIV on new infections in British Columbia. And I'm going to share with you also new data as recent as of last week. As such, some of these analyses are preliminary, but overall you'll be happy to know that the trends that we have been reporting to date have continued in a very positive way. Before I start with the data, I want to make a few remarks regarding the unique aspects of the data that I'm going to share with you. The data is population-based. What that means is that it's not clinical-based, it's not program-based. This is the data as it pertains to the whole of the province of British Columbia. Health in Canada, as you know, operates under federal regulations within a socialized scheme, but the health programs are administered provincially. So the HIV program in the province of British Columbia is different from the HIV program in other provinces. So this is a unique opportunity for us to explore how our different policies have impacted in our province. So there is free access to highly active antiretroviral therapy, and there is fully free access to medical monitoring, implying viral load, resistance, TDM, genotypes, whatever you want to include there. All data is captured centrally. For the therapeutic data sets, the BCCFE, our group, is responsible for it. That includes distribution of antiretroviral therapy as well as therapeutic outcome related measurements. For surveillance, we rely on our colleagues at the BCCDC who are working in partnership with us in this endeavor. We also have, as background measurement of risk activities, access to blood-borne diagnoses from the BCCDC. I will not be sharing those data with you today. And of course, we have multiple additional data linkages with multiple data sets, most importantly, the Vancouver Coastal Health Authority, who are co-authors in this piece, who carries about 75% of the load when it comes to HIV in the province. We have access to community-recruited cohorts of at-risk populations. These are independently funded, predominantly through CIHR, NIDA, and other sources, which allows us to characterize behaviors, including risk compensation, etc. I will not discuss that in detail, but those data are available, and much of that has been published. As I will discuss in a moment, we have distinct phases in this observation. We have retrospective data as well as prospectively collected data in the attempt to relate the expansion of HAART on the key variables of morbidity, mortality, and HIV new diagnosis. I will share with you complete data until September 2011 unless I otherwise indicate. This is a slide that I have not updated out of being lazy. Because really there is no much to update. I have used it before, and it highlights for you the phases of antiretroviral therapy rollout in the province. The early phase is the patients participating in the INCAS trial, the triple therapy trial that was disclosed in the summer of 1996 at the Vancouver conference. You see here phase one of our rollout. It started very early on, in fact, before the conference, because we had the ins on the data that was going to be emerging. You see that plateaus by the year 2000, after which we enter a steady state phase. Upon recognizing this effect, the effect of this rollout on HIV new diagnosis, we negotiated with the province the re-expansion of antiretroviral therapy use, and what you see here is a steady phase of expansion of the program, which has now reached 7,500 patients by the end of 2011. This is out of an estimated 12,000 people infected with HIV. That estimate pertains to the Public Health Agency of Canada. Is not our estimate. We think that there is some room for debate there, but it's the best number that we have. First, I'll show you all-cause mortality for HIV-infected individuals in the province of British Columbia, and I'm happy to report that the trends are, as you can see here. We have seen a rather dramatic decrease on mortality in the province, coming down to almost negligible numbers in 2011. Let me emphasize, our cohort is getting older, and yet the death rates are quite remarkably low. Our patients are living longer, and they're living healthier. As illustrated in this slide. This shows AIDS diagnosis before and after initiation of highly active antiretroviral therapy. On the dark blue is before, and on the light blue is after the initiation of antiretroviral therapy. And hopefully this gives you a sign that we are improving in our ability to bring people onto treatment at earlier stages, in that less people have AIDS diagnosis before starting treatment, and of course, many less patients have AIDS diagnosis upon starting antiretroviral therapy. So we're having the desirable impact both in AIDS-related morbidity and in all-cause mortality to, I would say, a fairly impressive extent. This shows you the CD4 count before starting antiretroviral therapy. The data necessarily is a little bit messy in the early days because of two confounding elements. One is the rapid increase of people going on to treatment at a time in which the guidelines were very generous in terms of who we were offering treatment, but also there are a substantial number of people that are coming in already on dual therapy, so the CD4 count here may be slightly inflated. You can make out of that whatever you want. There are multiple ways in which we can analyze the data. At the end of the day, the important thing to realize is that in the 2000 years, in the early 2000s, when we went through that sort of conservative phase in the use of antiretroviral therapy, where we were less inclined to offer treatment at early stages of HIV, the median CD4 count has been increasing steadily, and is currently, for the first time, approaching 400 as a whole in the province. You have here indicated the different strata of CD4s. On the dark purple, you have less than 50 cells, 50 to 200, 200 to 350, 350 to 500, 500 and above. So as you can see, since in 2010, following the Melanie Thompson et al. IAS USA JAMA publication of the guidelines, which were rapidly endorsed in British Columbia, we have seen a salutary effect in terms of being able to successfully offer antiretroviral therapy to people increasingly at higher CD4 counts. You see here the expansion of the number of people with above 350 CD4s entering treatment, more so in later years. To me, it's most gratifying to see that these darker sections of the columns are collapsing rather quickly. Adherence is shown in this slide, and we use a measurement of adherence that is based on refill compliance, and we can do this reliably because we have electronic access to this data. Refill compliance has now been shown to be highly concordant with any other MEMS caps or recalls, etc. It's predictive of mortality, predictor of disease progression, so we're very comfortable that this is a good measurement to use. We use it on the first year as a marker of individual behavior because as you use adherence in successive years, there are a number of biases that creep up. In other words, people who get sick or die certainly are not going to adhere as well, and so that creates problems in terms of the interpretation of the data. As you expand the antiretroviral therapy program, necessarily you tend to include more and more people who are in more challenging environments. We are now being able to incorporate more IDUs and more people with harder lifestyles, and so it's reassuring to see that our overall adherence trends have remained stable, particularly over the last several years, at a rate not quite but almost 70%. The data for September The data for 2010 is only encompassing, you can't see it there, but it's only up to September 2010. We're a little bit slower on our linkage with the refill compliance data. This is the actual viral load data. It's hard to show it in any more elegant fashion than this table. Bear with me. What I'm showing you here is the number of people tested. I'm showing you here the people with less than 50 copies and less than 500. This is everybody ever tested in the province in that particular year, whether this is a mistake, whether on treatment or not. And what you can see here is that 56% of the people that we have data available for are suppressed at less than 50, 71 out of less than 500. As I said, PHAC estimates that there are 12,000 people infected with HIV in the province. So you can change that N to the 12,000, and that's the best guess of where we think the community viral load would be. So this would be 56% over out of 10,000, almost 11,000. So you need to discount another 1,000 patients to that percentage if you want to get the broader sense of how many people in the province as a whole are suppressed less than 50 or less than 500. We use for these calculations the highest viral load in the patient on that year. So this is a conservative estimate of the level of suppression. All in all, we're making significant progress. As you can see, the trends are steadily improving over time. Not surprisingly, as the program continues to successfully suppress viral replication, you see that there is a decreasing prevalence of HIV drug resistance among patients on HAART in the province. And what this shows is that the proportion of people that are suppressed on treatment, it shows here people who are either with wild-type virus, despite the fact that they have detectable virus, and the proportion of people with resistance is shown here. There is a small group of people that have not been genotyped for whatever technical reasons, maybe their viral loads may be too small or there was no residual sample. We do this as a standard of care, so there need not be a request for resistance testing. We have here 1-class resistance, 2-class resistance, and 3-class resistance. I think the important thing to realize is that despite the fact that the program is expanding, the proportion of individuals with resistance, contrary to some of the pessimistic modeling papers that have been published, our data, our field data, populational data, suggests that you can expand antiretroviral therapy and still see a relative decrease on resistance. This is, again, new data. Chanson Broom has a poster expanding on this, and I would encourage you to discuss the details of this with him further. But this is showing drug resistance among antiretroviral therapy naive patients at the starting on HAART. Again, as part of the standard of care in the province, every viral load in a naive individual starting HAART is processed for resistance. We do that so that we can guide decisions upon initiation of treatment and avoid the mistaken use of suboptimal regimens. And what you see here is that there has been a decrease on the trend in terms of primary resistance, although it seems to be relatively stuck at somewhere around or shortly below 10%. We are currently discussing what strategies we're going to take to approach this issue head-on to be sure that there is no further increase on primary resistance. And Richard Harrigan, myself, and others are looking into that. Let me move on now to the update. This is new data as of last week regarding new diagnoses in the province for the year 2011. This is the number of people actively on treatment in the program. And notice that this is people active on treatment. And then you have here HIV new diagnoses coming down over time in a statistically significant fashion. I'm happy to report that we had 301 new diagnoses in 2010, and despite the fact that we have significantly increase the number of HIV tests that we do year after year, particularly through the efforts of Rekha Gustafson and others in Vancouver Coastal Health. We are actually finding less cases overall in the province. 2,089 is our last count for 2011. We have stratified these by non-IDU risk factor, and I'm happy to tell you that the 50% decrease that we were able to identify in 07-08 seems to be persistent, and in fact, that trend slow but steadily continues. Now, people have argued that, well, if Canada has a socialized medical system, maybe this is happening just everywhere all the same. The answer is simply no, that is not the case. If you look at this slide, this is data from the Public Health Agency of Canada that has been reworked by Bob Hogg, presented last week at the Canadian Association for HIV Research meeting. If you now stratify the country by regions, you find that British Columbia demonstrates this kind of year-to-year rates of HIV new tests, HIV positive tests, that is. And again, using the PHAART data, that's the reason why it's only available to 2008, we see that no other region in the country has shown a significant decrease on HIV new diagnoses, and quite worrisome, some regions are actually showing significant increases. This is driven primarily by an epidemic in Saskatchewan, in the prairies, where there has been a 5-fold increase in HIV new diagnoses since 1996. There is a First Nations epidemic predominantly, and also an IDU epidemic in that area that is unfortunately out of control at the moment. So in conclusion, the BC highly active antiretroviral therapy expansion has been strongly and significantly, in a sustained basis, associated with decreases in age-related morbidity, all-cause mortality, as well as HIV new diagnoses. Our results support the long-term sustainability of the HAART expansion strategy within the HIV treatment as prevention framework. We are currently looking at ways to further optimize the cascade of care, to explore further formally the role of incentives, and we have a NIDA-funded incentives clinical trial, randomized clinical trial, that we're going to superimpose on this population to see whether that can be a mechanism to engage more people into testing, more people into treatment, more people into viral suppression, particularly among very hard-to-reach individuals. We're currently negotiating with the government further efforts to expand outreach efforts outside of the most affected areas. We feel, based on our efforts, that there are pockets of unrecognized HIV outside of the worst affected areas that need to be further engaged. Vancouver Coastal Health Authority has done a tremendous effort in terms of normalizing HIV testing, and we would like to see further normalization of HIV testing as part of standard of care and policy for the province. We need to further enhance our linkages, particularly with the correctional system, and we are currently doing further work to try to formally look at the cost effectiveness of all of these. Obviously, it will turn out to be very favorable outcome at the end of the day, but we'd like the numbers to support our impressions. I'd like to acknowledge, first and foremost, all of the people infected with HIV in BC that have been very strong supporters of this initiative from the very early day. I'd like to also, first and foremost, acknowledge the unwavering support that the government of British Columbia has had for us to implement this kind of approach, even at times when it was a little bit tentative, as well as our multiple partners and collaborators, PHC, Vancouver Coastal Health Authority, Northern Health Authority, Provincial Health Services Authority, our very supportive community, and as I said, the Minister of Health, as well as NIDA in particular, who has been very generous with funding support for this work. Thank you very much.